Next, we'd like to very much thank our platinum sponsor, Bayer, and Professor Ishida from my university will be giving the industry lecture on experience in cardiovascular MR from Japan.
Thank you, Chairman, for the kind introduction, ladies and gentlemen. I'm truly honored to be invited to this exceptional opportunity. Today I am talking about experience in cardiovascular MRI from Japan. So I have nothing to disclose. So I would like to mention firstly growth of CMR in Japan. So this slide illustrates the annual number of cardiac imaging studies in Japan. Coronary angiography is still high, but gradually decreasing recently, while the cardiac CT is rapidly increasing over the past 15 years. But cardiac MRI is relatively small number, but as Professor Sakuma explained, it is rapidly growing in almost 13% per year in the last decade. So here is Mie Prefecture, where I am based, and here is Sendai, by the way. And we analyzed the number of the cardiac MRI studies in Mie University Hospital and in the other 8 clinical hospitals recently. And this graph shows that CMR protocol used in Mie University Hospital and 8 clinical hospitals in Mie Prefecture. As you can see, lead gadolinium enhancement is almost performed in almost all cases, but stress perfusion in University Hospital is less than 30%, and more than 60% in the clinical hospital. The difference of these between these hospitals are attributed to the fact that we recently introduced advanced cardiac CT, including the cardiac stress perfusion CT and late enhancement CT. And tumor mapping in our hospital is very high, whereas the incidence of the tumor mapping is relatively small in the clinical hospitals. And this represents a trend of CMR towards for the cardiomyopathy. And also it should be noted that coronary MRA incidence is similar between the hospitals. So today I would like to focus on the stress perfusion MRI, coronary MRA, and non-ischemic myocardial disease. So this slide shows that typical protocol for the stable coronary artery disease, including CINE MRI for the assessment of LV volume and function, and stress and rest perfusion MRI for the assessment myocardial ischemia, and late gadolinium enhancement for myocardial infarction and fibrosis. And coronary MRA is optional, but in case of in the de novo case of the stable coronary artery disease, we routinely performed coronary MRA in our institution. So this is ESC guideline for the diagnosis and management of chronic coronary syndrome. In this guideline, coronary CTA is recommended if the pretest probability is intermediate to lower. And in the case of the pretest probability of intermediate to higher, the stress imaging, stress CMR, is recommended to rule in or rule out the coronary artery disease. And this is the Japanese guideline, which was updated last year. This is very similar to the ESC guideline, saying that if the pretest likelihood is low, coronary CT is recommended, but it is higher, coronary stress perfusion imaging, including the stress perfusion MRI, is recommended. So we are following this guideline at the moment. Then let me show you an example of the stable coronary artery disease. In this 50-year female with chest discomfort with multiple risk factors, as you can see, there is subendocardial infarction in the anterior to septal wall from mid to apical slice. And you may also notice that stress-induced ischemia, transmural perfusion defect in the same territory, which represents existence of the LAD stenosis. That was proven by the coronary angiography. Then diagnostic performance of stress perfusion MRI is actually very high. This is the same slide with the previous presentation, but we demonstrated that diagnostic accuracy is significantly higher than the cardiac SPECT. And after this paper, many similar results was reported. And now the stress perfusion MRI is one of the most accurate technique to diagnose the cardiac coronary artery disease. And this recently, Professor Nagel reported that myocardial perfusion MRI is non-inferior to FFR to guide the PCI in a stable coronary artery disease patient. And interestingly, myocardial perfusion MRI was associated with a lower incidence of coronary revascularization than FFR. So now we can stratify the so we can use the myocardial perfusion MRI as for the therapeutic decision making for this kind of patients. And let me show you another case. Case 1, as you may notice, there is LAD perfusion defect in the LAD territory. And also in case 2, you may notice the LAD territory perfusion defect, but the area is different. This case 2 is larger perfusion defect. So what does the difference mean in the clinical practice? So this is the result of the SPINS trial, which is a multi-center registry study done in the United States. This result represents that area of the perfusion defect is very important, which can stratify the patient prognosis. So now we can use the stress perfusion MRI for the accurate diagnostic tool, as well as for the prognostic marker. Okay, so as Professor Sakuma mentioned in the last talk, if you measure the coronary sinus blood flow by phase contrast in MRI in the resting state and during stress, you can obtain the global CFR. So this is a recent report from by our colleague, Dr. Nakamura. Based on this result, interestingly, if you don't see any ischemia, but CFR is decreased, that patient has a similar risk, at risk with the patient with ischemia, but CFR is maintained. So global CFR can very useful for further stratify the patient prognosis in the patient with stable coronary artery disease. And recently it is available to quantify the perfusion MRI, especially if when we introduce the dual sequence method as a perfusion map, as shown on the right-hand side. So, but this is a result of the CMARC sub-study demonstrating that visual assessment in terms of the accuracy of the diagnosis of the CAD, the visual assessment is almost similar to the quantitative assessment. This result at least encouraged us in terms of we can obtain the similar result without the lengthy learning curve. But in this 60-year-old female with multiple risk factors, we performed perfusion MRI. You may notice diffuse subendocardial perfusion defect. So initially we thought this patient had a triple vessel disease, but actually, as shown on the coronary CTA, there is no significant stenosis at all. So this is the example of the coronary microvascular dysfunction, CMD. So recently, the group from London demonstrated that global stress MVF, quantified by the perfusion MRI, can distinguish the CMD from the multi-vessel, triple vessel disease. So we are at the moment planning the study to validate this kind of result because this study, the number of the patients recruited in this study is relatively small. Okay, I'm moving into the coronary MRA. So this is a typical imaging method for the whole heart coronary MRA. So respiratory gating by navigator echo technique. So which is acquired during expiratory phase by monitoring position of the diaphragm. And typically navigator gating efficiency is 30 to 60%. But this is a relatively old technique. And advantage of the coronary MRA includes no ionizing radiation and feasibility of non-contrast study at 1.5 Tesla, and also insusceptible to coronary calcification. So in this 60-year-old woman with effort angina, initially coronary CTA was performed, but because of the heavy calcification in the mid-proximal RCA and proximal LAD, it is impossible to judge if there is stenosis or not in this segment. Then we acquired the whole heart coronary MRA and revealed that no stenosis exists in the RCA, proximal RCA, but tight stenosis in the proximal LAD. That was proved by the coronary angiography. And this is diagnostic accuracy of the 3T contrast enhanced 3T coronary MRA. It is very high, but this is a single center study. And at the moment, we have 3 multi-center studies for the diagnostic performance of coronary MRA. And we should notice that at 1.5 Tesla using SSFP sequence. Whole heart coronary MRA has 88% of sensitivity and 72% of specificity. And at 3T, the diagnostic accuracy is relatively high compared to the 1.5 Tesla. And recently, Dr. Nakamura reported that coronary MRA can be used for the stratification of the patient prognosis. And in the long-term follow-up, as you may notice, the clearly stratified based on the number of the diseased vessels, as shown on this slide. But there is a limitation of coronary MRA, which is lengthy imaging time and operator dependency. So with the collaboration with Professor Matthias Stuber, Lausanne, we recently introduced a free self-gated, free running 5D coronary MRA. This slide explains the free learning acquisition. So using the golden angle radial sampling and continuous acquisition, you can bin the cardiac dimension and respiratory dimension. And we use this technique at 3T by using the contrast enhancement. As you may notice, we obtained the very, very nice coronary images using this technique. The advantage of this technique is just set up the volume of the FOV and click one button, that's it. So we can obtain this kind of images. But normally we used only one cardiac phase and one respiratory phase. So the image data can be reconstructed for the cardiac dimension to obtain the cine images. And then we compared the 2D cine images. And as shown on this slide, the agreement was very good between 5D free running cine and 2D cine. So now we can obtain coronary images and cine images with fixed time with minimal operator interaction. Then I would like to move into non-ischemic myocardial disease. These graphs indicate that sort of a pandemic of the heart failure in Japan. So as you may notice, the incidence of the heart failure is will be very, very high in 10 years or so. So now we are more and more focusing on the heart failure and myocardial disease. In this talk, I would, and this slide shows the paradigm shift to the multiparametric mapping for the evaluating myocardial disease from the conventional technique. And I'd like to focus on the DCM in my talk. So this was done by our colleague, Dr. Nakamori, who is a cardiologist, shown that even though there is no LGE at all, but T1 is different. And in the biopsy specimen, the fraction of the collagen is very associated with T1 value as well as ECV. So we can recognize disease severity by using T1 mapping especially when we don't see any LG finding. And this is a very nice study from China. As you can see, if there is no LGE, native T1 and ECV can still stratify the patient prognosis. Okay, so this is last slide in my presentation. This slide explains that the relation between native T1 ECV and reverse remodeling, because in DCM patient, it is very important to know the efficacy of the drug treatment. And as you can see, the difference of the T1 value between initial examination and follow-up examination is linearly related with reverse remodeling. So, especially in the cardiomyopathy patient, T1 mapping is very, very useful. Oh, sorry. Okay, thank you for your kind attention.